skills will be tested. And of course, in our earlier meetings, we had some very senior and very tough examiners. So this time, fortunately, we don't have, hopefully, not that tough examiners, because Dayasagar Rao and Dr. Krisham Raju, they used to make the student literally cry. So I hope you won't cry. But let's start the things. So we have 3 cases, a long case followed by 2 short cases. We'll stick to the time because we're all running against the time. So 11:15, we'll start with a long case. The examiners are Dr. Pahlajani sir, Dr. Satyavan Sharma sir, and Dr. Ramakrishnan. Okay, so you 3 will be the main examiners, of course, everybody else. Then there are 2 short cases. After the long case, the short case examiners are Dr. Sandeep and Dr. B. Srinivas from Nizams. Has he come? Has he come? Okay. And another short case, Srinivas Kumar, B. Srinivas, Rama, and myself also. So we'll just be around. So start with the first long case. Who's the presenter? Where is the... Oh, you are there? Okay. Sir, you want to sit that you be there or what? You want to get the chairs here. It's better because everybody can listen to them. Somebody call me.
ऐसा लग रहा है हम लोग एग्जाम हो रहा
है.
ऐसा लग रहा है we are being exam.
So you don't want the chairs there? Okay, fine. Okay, so take over, Rama.
The time on. Is it there? 20 minutes time. 40 minutes time. We finish the exam by 40 minutes and then have the X-ray CG and the try to finish by around 1 hour. 40 minutes to make it.
Good morning, sir. So I will start with history. 35-year-old male patient, resident of Narsimapet, farm laborer by occupation, completed primary schooling, come from a low socioeconomic class, come with chief complaints of dyspnea on exertion since last 3 years and palpitation since last 6 months. Patient was apparently all right 3 years back when he started developing a breathlessness on exertion, which was insidious in onset and gradually progressive. Initially, he started developing a breathlessness on doing his farm dialysis. For above complaint, patient was admitted to the hospital 15 days back and he told to have a heart disease for which he required a surgery. And he given an IV medication and oral medication which increases his urine output. And also one pleural tapping was done, around 1.5 liter of fluids was removed, which was pale in colored. Followed by patient felt symptomatically better and he able to perform his daily activity with improvement in his sleep. There is no history of abdominal distension, facial puffiness, pedal edema, no history of angina, syncope, or dizziness, no history of hoarseness of voice, dysphagia, or CVA, no history of prolonged fever or joint pain, no history of cyanosis or any recurrent respiratory tract infection in the childhood. Shall I proceed with past history, sir?
So this is the history of a patient for last 3 years.
Yes, sir.
And has been gradually worsening.
Yes.
And recently required a hospitalization.
Yes.
During hospitalization, the patient received IV medication and also required a pleural tapping.
Yes.
So how do you synthesize? What do you understand with the history? What might be happening to the patient?
Yes, sir. So definitely there is a...
Will you like to put it in some hemodynamic terms or in terms of what might be happening? Is the patient getting heart failure? The patient is getting
Yes, it's a definite one episode like palpitation is recent onset, followed by development of PND and orthopnea. There are correlating. Like last 6 months he had in PND. Since 3 months he had palpitation and worsening of symptoms like orthopnea, and followed by 15 days back, which is relieved like a pleural tapping. Indicate CCF was recently developed, might be precipitating because of the arrhythmic event like palpitation. So likely a stable hemodynamic wise, like any MS or any inflow obstruction that is precipitated because of the arrhythmia, and a patient developing the symptoms now like heart failure.
You think it's in a you think it's in a biventricular failure like this?
Sir, in history wise, like pedal edema, ascites per se is not there, but pleural effusion we can consider might be a right heart symptom.
So can it be anything else? Pleural effusion? Even though we think that it could be right heart.
Yes, sir.
But suppose somebody develops pleural effusion because of right heart failure, definitely should have at least some pedal edema or something else
Yes,
has
sir.
to be there.
Yes, sir.
So what are the other possibilities you will consider?
Yes, sir.
Because tapping, pleural tapping is a not common
Yes.
presentation.
On looking to the patient, sir, he is totally emaciated, cachexic. So in our country, we should think of tuberculosis the first.
One could be the additional pathology you want to bring.
Yes.
Can this be anything else? Can left heart disease produce pleural effusion?
Yes, sir, possible.
Yes, sir.
Possible.
Any other possibility? Recent onset there.
Could it be a cardiorenal syndrome where patient has got a renal along with the congestive cardiac failure patient or some renal
So
disease?
possible in that case, facial puffiness would think, but possible, sir. Pleural effusion because of cardiorenal possible.
Another possibility will always be pulmonary embolism.
Yes, sir.
You can finish the history.
Yes, sir. So past history, there is no history of diabetes or hypertension, no history of past tuberculosis or asthma. There is no previous history of hospitalization. There is no history of any taking in monthly regular injection and no history of drug abuse. He is married, having 2 kids, consume mixed diet, normal bowel and bladder habit. He is smoker. There is no drug allergy. Family history is born of non-consensuous marriage, no history of sudden cardiac death in family, and there is no heart disease in the family member. Yes. So 35-year-old male patient presented with dyspnea on exertion since last 3-year duration, which likely precipitated by arrhythmic like AF like atrial fibrillation with history of pleural tapping, likely indicating a congestive cardiac failure.
Sorry for the interrupt. The students for the short cases, Dr. Pradeep Bansal and Dr. G. Kumar.
So from your this history, what etiologies are possible? You got my question?
Yes.
Yeah. So this is a history which you told is essentially looking like a left heart failure,
Yes.
and you thought the left heart failure was precipitated by atrial fibrillation,
Yes.
by an arrhythmia, most
Yes.
likely atrial. So what etiological groups will come to your mind?
Yes. So as such, there is no history of past rheumatic heart disease, but still 50% cases might not have any history of rheumatic heart disease. We can think of first like rheumatic heart disease in our country, followed by the history is not like long duration, like 3 years of dyspnea only. If it is an MS, I would expect might be a long duration. It could be like MVP, MR might be precipitated by some.
So one is this can be a valvular heart disease.
Valvular
That's
heart
what you are
disease,
trying. It
RS.
can be a rheumatic heart disease. Any other group it can be?
So MR, like other causes like myxomatous mitral valve.
Okay. So it can be a, let me put it in a more broader way. It can be a valvular heart disease,
Yes.
either rheumatic or degenerative, or any other etiology.
Yes.
Any other group you
Yes,
will
sir.
consider?
Myocardium problems, something like cardiomyopathy can also be present like this.
Can you think of any congenital heart disease?
Congenital, sir, I specifically asked in history in the past, like increased pulmonary blood flow situation. He's denying. If you take that as a soft point, then we can keep as a lower most point. Could be a concern.
Do you think of any congenital heart disease which can be present with atrial fibrillation like this? Or would give rise to kind of a biventricular failure like this?
So at this age, like 3rd to 4th decade, we think of ASD, but development of arrhythmias is more after 40 years. Still can be possible.
You can summarize this again because summary is something that should get the essence of the case. And can you try, because this is an exercise for everybody. You can summarize again.
So 35-year-old male patient presented with dyspnea on exertion since last 3 years duration, which precipitated by arrhythmic event, likely atrial fibrillation, with history of a pleural tapping indicating a congestive cardiac failure. My likely diagnosis is a valvular heart disease, likely rheumatic heart disease with severe MS.
Anybody wants to improve it, like anybody wants to, there are some critical essential features that are missing in the summary, which has to be there. So what is the NYHA functional class of this patient? To start with 3 years back,
So
what it has become.
He's a 30.
That course is not there. That should be out and out in your summary.
initially started
It starts
with
with
class
now
2
in class
and
4.
deteriorated since last 6 months.
So your PhD and orthopnea have such critical symptoms that's not missing in your summary. That must be there in your summary. This is an exercise for you. So it's not for just to point out fingers, but it's supposed this is an exercise that you get the crisp case out in that line. So because orthopnea and PND are such symptoms that give you a lot of clues. So what are the congenital heart disease that can produce PND? PND is such a symptom that what congenital heart disease can produce PND? Except for congenital MS, you can't think of anything
Yes,
else.
Congenital mitral stenosis.
Stenosis is the only thing. Very unlikely that you will present with congenital MS. So what about pericardial disease? Because only has dyspnea and palpitation, arrhythmic palpitation, AF. So can this be restricted cardiomyopathy? Can this be constrictive pericarditis? Can this be dilated cardiomyopathy?
Sir, constrictive less likely because PND and orthopnea is that severity of disease is less.
Suppose what is the LA pressure?
It's same in all.
So it's roughly 25. Suppose RA pressure is 25. LA pressure will be 25. Why there is no PND?
Because of the interventricular interdependence, the pulmonary veins are outside.
We don't know. We don't understand. Some of the explanation is that some of PND plays a role in precipitation of there are theories written about it. We should know that BNP is not so high and that somehow protects against the development of PNP. And it's a long-standing happening, so then lymphatic and other various compensatory mechanisms are what? It's not a acutely developing disease. So these are the various things. What about AF and CCP? Suppose this is AF and CKF.
Possible
It's possible.
What percentage of CCP have AF?
5.
It's uncommon. Like roughly say 1/3, maximum is 1/3 of them can have atrial anemia. So it's again uncommon. So these things will make it CCP uncommon. What about RCM? Can this be RCM? Because you said cardiomyopathy is possible. That's why I'm asking you all this.
Cardiomyopathy, yes, sir.
So suppose if this is restrictive cardiomyopathy, can you only develop total deficient not have any condition?
RCMP will be in predominantly RV failure features like pedal edema and abdomen distension with the predominant
Most of
symptom.
the prototypic idiopathic RCMP will be predominant right ventricle.
Yes.
You're not getting any features of that. Again, that is unlikely.
Yes.
You are most likely dealing with
Who's dealing with the valvular heart
Valvular.
disease of LV side likely to be stenotic lesions.
can this be thromboembolic PH?
Sir?
Thromboembolic PH
No history of like sudden onset features.
that may not be there. Vast majority of it is not there.
So orthopnea less likely in case of
Orthopnea and TND are not. a
PND
feature.
are
And
not.
right heart symptoms like
Those are very classical features that take it out.
Yes.
So with the history of PND and orthopnea, you remain restricted to either a myocardial disease or a left heart valvular disease. That on that basis, you can exclude pulmonary hypertension, constrictive pericarditis, pericardial disorders.
What is the mechanism of PND? Why do you get
So
PND?
PND is because of various mechanisms. Most common accepted theory is because of REM sleep. In case of REM sleep, there will be increase in sympathetic activity, and that because of the tachycardia, there will be increase in the LA pressures, and that leads to this like sudden breathlessness. Apart from this, the interstitial fluids start getting accumulated in the intravascular compartment, and that leads to that. Apart from this, there is decrease in the sympathetic surge during the sleep. These are the three classic mechanisms explained of PND.
What are the mimickers of PND? What are the diseases that can
Dyspnea
be like PND?
So it can be COPD, bronchial asthma, sir, bronchiectasis,
Nocturnal asthma.
nocturnal asthma, sir,
GRD
or
pacemaker.
GRD.
Obstructive sleep apnea.
Yes,
OSA,
OSA also.
So can be.
Yes.
one of the most
Yes,
important
one of the
cause
most.
one has to keep in mind.
What is the difference in history between orthopnea and PND? I'm trying to bring out the common classical questions for
It's
everybody.
relieved by the
Yesterday
upright
they-
position.
Okay.
In the orthopnea, patients get relieved by the.
Yesterday only, actually, I talked in my lecture,
PND,
quite a lot of difference. Tell us for benefit of everybody.
Orthopnea is relieved by the sitting upright position. PND usually takes time to relieve. And it develops, orthopnea develop like within a 15 to 20 minutes immediately going to the recline. Whereas PND develop time to develop like 2 to 3 hours to develop, but can rarely possible, can early also.
What about recurrence?
Recurrence in the one night is less likely because patient again going to sleep for 2 to 3 hours, and that activity of REM will be not there. In
PND is unpredictable, like may not happen again, but
May not
orthopnea repeatedly happens unless it takes another pill, like.
Yes.
I think we can go further.
Examination.
So just before that, what valve heart disease? Suppose we think it's valve heart disease. So is it one valve or two valve or which valve heart disease?
It's a multivalvular heart disease.
Why multivalvular?
So one is patient is having orthopnea PND, so it's LV intro obstruction. Apart from this, patient is also having pleural effusion, so might be associated with the RV, the TR.
It's like MS with involvement of
MRC
DR,
involvement.
or less likely like could be other wall also, but as such history not pointing towards that. But most of the time we know RSD is involved with multivalvular disease. It could be think of like LV dysfunction.
So what are the histories you have in your the primary possibilities MS PR? What are the other features that you should have asked? Like some of the things may give you a clue. One thing could be a prominent neck pulsation. So prominent neck ask for there is no history of prominent neck pulsation. When you are describing no pedal edema, no right hypocaudal pain. No effective.
But this all history can be a single valve.
Yes, sir.
Just a mitral stenosis, maybe mitral stenosis, mitral incompetence, or just a mitral stenosis got complicated by atrial fibrillation.
So what are the other functional classes apart from NVHA?
The Goldman specific class and Brogg assess visual analog scale, then Duke's activity.
First as a cardiologist, first thing should be.
NYHA plus.
Canadian.
So how the Canadian classification is different from NVHA classification?
They use the objective ways of measuring the height, like walking the.
That's one.
Yes, sir. And they included the strenuous activity in the class 1, that not there in the NYHA class 1.
So there is something called CCS 0 is also been described.
Yes,
It is not there in NVHA.
NYHA.
Yes, sir.
And anything else? What are the symptoms that can be classified with CCS and that can be classified with NVHA?
So in your CCS, angina is the predominant.
Only angina is
Only
classified with
angina.
CCS.
For
Whereas with
chest
NVHA,
Here angina.
Palpitation, palpitation, dyspnea, fatigue.
So angina, syncope,
Dyspnea,
palpitation and dyspnea. sir.
syncope is there in
Syncope
NVHA.
is in WHO for PH
Fatigue
classification.
bleeding.
So what are the 4 things that are classified in NVHA?
Fatigue, breathlessness, angina, and palpitation.
So WHO should know. How do you classify in a child?
So child we use
There is Ross classification of the heart failure, while
So there is a modified ROS
Modified
scale,
ROS.
which again uses a similar pattern,
Hmm.
but uses the children activity like
Children's
crying and
activity,
feeding
crying.
and all those things. What is ROS score?
Ross score.
The ROS score is an objective score including heart rate and everything in an objective fashion that's used more for clinical studies.
Clinical.
It gives you some number. So these are the various things you should know about functional classification.
The general physical examination. Patient is conscious, oriented to time, place, and person. He is a thin built and emasticated. Height is 146 centimeter, while weight is 46. BMI is 17.9. Respiratory rate is 20. Pulse is 112 beats per minute. Irregular, variable volume, normal character, normal condition of the vessel wall with no radial or no radiofemoral delay. Blood pressure is 110 by 80 in the right upper arm supine position, while left lower limb it is 114 by 80. Saturation is 98% at room air. JVP is raised pulsatile 8 centimeter above the sternum angle at 45 degree with prominent CV waves. No pallor, icterus, cyanosis, clubbing or lymphadenopathy. Back and spine are normal. Serious inspection and palpation. Trachea is in the midline position. Chest is bilateral symmetrical. Apical impulse is the 5th intercostal space. Medial to the mid-clavicular line. Tapping in nature. Palpable P2 diastolic thrill is present at the left 5th intercostal space. No impulse, scars, sinus or dilated veins.
Be slightly slow, yeah. Be slightly slow. Like for example, you get 1 hour for your long case. If you finish your, whatever you have to talk in 5 minutes, we give examiner 55 minutes of asking questions.
Yes.
When you said irregularly irregular, what do you mean? What is the, why is it irregular?
It's atrial fibrillation, sir. Atrial fibrillation.
Why did you just twice? Why don't you just say irregular?
So only irregular, it can be even in case of
So like bigeminous plus or
Bigeminous.
trigeminous plus is irregular, but regularly irregular. Regularly irregular.
Huh.
Like in this case, it's a regular,
Well, sometimes-
irregularly irregular.
Sometimes PVCs can just come at sort of will, at its own will. So it's irregular. So why this is called irregularly irregular? Every time we say atrial fibrillation, irregularly irregular. Why it is twice irregularly irregular?
So first, when we say the regularity of irregularity, if it is the irregularly irregular means that irregularity is not coming.
It is irregularly irregular in the rhythm as well as is irregular in volume.
Okay. Rhythm.
Once volume keeps on changing.
Go on. You said diastolic thrill. What else?
yes, a diastolic thrill is there, palpable P2 is there, parational EU of grade 3, and there is no scar sign or dilated veins. An apex impulse is the fifth intercostal space, medial to the mid-clavicular line, and tapping in nature.
Did you get a parasternal heat?
3 by 3. Sir.
Great.
3 by?
Great.
Grade 3, sir. Sir, percussion. Upper border of the liver ulnus is the right fifth intercostal space, suggestive of situs solitus. Left heart border corresponds to the apex. Right heart border is substernal, and left second intercostal space is dull.
How did you measure the blood pressure?
We have to take the multiple readings in presence of air.
In
Did you use
atrial,
a mercury manometer or a aneroid?
so oscillometers.
Oscillometric. So how does oscillometric DB measurement happen? Like?
So oscillometer works on the principle of easily
Does
identify.
it listen to cortical sound like you do?
No, sir.
What does it do? How
Means
does it pick it?
Presence of the first
Pulse
pulse.
volume, sir, it identifies that oscillometer identifies the maximum amount of that pulse volume that determines.
This all everybody should be clear. Like, we cannot. Anybody can be passed without knowing S2, S3. Missing an S3 also can get passed. But however your blood pressure manometer measures blood pressure, we don't know whether it should be allowed to pass a cardiac exam. I don't know. This I think everybody should be clear. So my question why I am coming is, can this whole algorithm, because it looks at the graph and then estimate the blood pressure.
Yes.
Can that work in air? That is why my question was.
No, sir.
AF is such a common disease and the most important risk factor is hypertension. Leave alone this air, but at the population level, AF most common risk factor is hypertension.
Yes.
So how can you say that hypertension blood pressure measurement will not be proper in air?
So we can take the mean of
So
3.
what is the data saying? Can oscillometric blood pressure measurement be predictive in air? Or good enough in air?
Take multiple readings.
There are studies that have critically looked into this, and this is quite good. It's reasonable, but you have to measure 5 measures. But you have to use your usual method. So what are the precautions that you have to take when measuring blood pressure in air? Any precaution that you should take when measuring blood pressure in air? Or the usual way you should measure? One is you have to take at least average of 5.
Average of 5. Sir.
Anything else you should take? Anybody wants to, how do you measure blood pressure in air? Because AF at times the volumes are variable. At times you can get extraordinarily outliers like sometimes. That means some sound can be out this way or that way. That sound you are supposed to exclude when measuring blood pressure. So read about that. That's something that's very fundamental. That measuring blood pressure in AF is fundamental to cardiology.
Auscultation, sir. S1 is loud and variable. S2 loud P2. Opening snap is present.
No, loud P2, what is? Like you cannot pass off like your assessment of JB was perfectly fine. You said all the things that are to be said. Same way S2, you have to say all the things. You cannot just say P2 is loud and move on.
The patient
No.
has a fast ventricular rate, like around 120. It's very like looking.
Is it split two sounds are
The no split cannot be appreciated.
Is it is to single
Not single, like narrowly split.
Say that and then get away. You cannot just eat away a split in final exam. Okay. S2, P2 is loud.
P2 is loud and
Narrow.
a narrow splitting of S2, sir.
Okay.
With opening snap present, sir. So there are two murmurs. First is a mid-diastolic murmur of grade 3/4, low frequency, rough rumbling in nature, best heard in the apex, non-radiating during expirations. Best heard during the expirations. And second murmur is a systolic murmur of grade 3/6, best heard in the left fourth if intercostal space, with the diaphragm of stethoscope during inspirations.
Where
Is
is
it
it,
ejection systolic murmur or pansystolic murmur?
So it was a pansystolic murmur.
why are you thinking so much? Right?
It's a pansystolic.
It's a pansystolic.
It's a
murmur.
pansystolic murmur.
Describe it again.
Sir?
Describe that murmur again.
So it's a pansystolic murmur of grade 3/6, best heard in the left fourth intercostal space with the diaphragm of stethoscope during inspiration. Best heard during the inspirations.
The murmurs you heard on the right side over the tricuspid area?
Right side.
No, sir.
Could not appreciate. Sir.
Anything missing in your MDM description? Again, describe the murmur again.
So it is a mid-diastolic murmur of grade 3/4, low frequency, rough rumbling in character, best heard in the apex, non-radiating during expiration.
Anybody wants to add?
So pre-systolic accentuation, not
Historic accentuation, then anything else?
So short A2 Os in
So you never talked about, you said OS present, but never talked about A2 OS gap.
short A2 Os.
A2 OS gap, what is the A2 OS gap?
So it determines the
Narrows.
severity of AS. With the severe AS, the A2 Os interval decreases.
Now, what is in your case?
narrow. Sir.
I mean narrow, sir.
So you should say that. So with a narrow A2 OS gap.
Narrow.
Anything else in the murmur? What gives you murmur quality? What gives you the severity of illness in MS?
So it's a long duration of murmur and
What
short
is the
A2
duration
Os.
of your murmur?
Long.
It cannot be long.
It
It will be variable,
variable.
obviously. What happens in your long cycle and short cycle, you have to describe.
Yes.
What is happening?
So with the short cycle murmuring, with the short cycle, there will be pre-systolic accentuation and the murmur will increase during the short cycle, which was like preceded by the long cycle.
So all of these questions, I would request you to think over your echo, because you are all echo generation. You understand echo much better. You've done hundreds of echoes of MS and you are first time observing a case in your exam. So don't put your money on your observation skill. Put your thinking on your echo skill. Think of the curve, how it is going to be in a short cycle, how the curve is going to be in a long cycle, severe MS, mild MS, moderate MS. All of you have done hundreds of echoes. So then extrapolate these findings here, what you have been asked.
Sir.
Any murmur you heard on the left sternal border, like aortic leak murmur or anything? Any other murmur you heard?
No, sir. Not.
What is the pitch of a murmur and what is the frequency of a murmur? You are using the word frequency, that's why I'm asking. What is the difference between the pitch of a murmur and the frequency of a murmur? Generally, it's a common mistake in using interchangeably. Generally, the frequency of the murmur is what is measured. If you are measuring it, you call it by the frequency. If you are hearing it, it's better to describe it as a pitch of a murmur. Same thing, high frequency murmurs are high pitch murmurs, low frequency murmurs are low pitch. But it's better to use the term pitch of a murmur.
What about the other system?
Other system examinations or respiratory system, there is a left basal crackles are present. Sir. And abdomen examination, there is no ascites. Central nervous system examination, no focal neurological deficit. And
Is the liver palpable or?
liver is not coming below, sir, means not large, not.
Liver is not palpable.
Yes.
You are getting such a high JVP, very large CV wave. How do you explain liver not palpable?
No pedal demand.
No pedal edema.
So one thing, patient is well diuretized.
So what is the sequence of disappearance of these three signs? Pedal edema, liver, and JVP.
The pedalema first to disappear, followed by the liver. JVP, pedalema, and liver.
JVP remains the last.
JVP remains the last.
That can be there, but generally you have to be really, as I is pointing out, when you have such a large JVP, you are likely to bound to get a liver. Make sure that it's not there at all by your palpation as well as by further.
And did you see for the pulsations also in the abdomen? Sometimes can see the liver pulsations. In such a case, the chances of liver pulsations, it can be there. So you should even a negative expression, you should tell, I looked for hepatomegaly, I looked for liver pulsations. They are not there.
So when you asked about pre-systolic accentuation, you said yes. Can a patient with AF have pre-systolic accentuation?
Sir, in a patient that
Short
after the short cycle, it's like long cycle followed by short cycle, there can be a pre-systolic accentuation because the gradient between LA and LV will be significantly raised. Sir.
Oh,
Can you summarize and tell us what exactly is your diagnosis?
So final diagnosis is valvular heart disease of rheumatic etiology, severe mitral stenosis with severe tricuspid regurgitation, with severe PH, moderate PVH, in atrial fibrillation, is currently in NYHA class 2 with no evidence of any infective endocarditis in congestive cardiac failure.
Now you said tricuspid regurgitation, but you described the movement. Was it getting accentuated on inspiration?
Yes.
So it was.
And it is being heard best in the apex?
Best left fourth intercostal
Parasternal
space. Parasternal region.
When you get such a severe tricuspid regurgitation, would you expect the liver to be pulsatile?
Yes, sir.
So then you say liver is not pulsatile.
So in this case, not there, sir, but I will expect the liver should be.
But when you said severe tricuspid regurgitation, I thought the liver should be pulsatile, should be palpable. And especially in the neck veins, you said they're so badly emboshed.
Yes.
Do you think this could be a vital regurg movement?
Sir, MR flow murmur can be there, sir,
Possible.
but there was a
Might be like rate
Loud.
is high, sir, in this patient rate around 120. And the murmur, classically like pansystolic murmur, it's radiating to the apex also. Apex also it's very visualized. So if you think like severe MR causing the feature of MS like flow can also be possible. Here in this case also history wise also it's long, not very long dyspnea, only 3 years history. But here the point toward the MS is like severe PH and AF. That could be.
no, we are not disputing MS. What sir is asking you, that rather than TR, is this a MR murmur?
it can be systolic flow murmur, but the only point goes against is there is a loud and variable S1, sir. Along with that, patient is having features of severe PH.
No, but in mitral regurgitation also you can have, if there is a combination lesion,
Apex
MS
is a-
and MR, you can have PH. So, what we are expecting you to tell is, how do you differentiate a TR murmur from a MR murmur? Very simple
Sign
question.
We can explain like
Hmm?
with inspiration is TR murmur.
and during expiration.
So
And
you,
the
you,
site of maximum.
yesterday we had
murmur.
discussed, you should talk about the location,
Yes.
where will be the location of, where will be the radiation, what will be the effect of inspiration. So all those points you should say.
Yes, sir. Cardiomegaly, hyperdynamic of predominance.
Is this murmur getting accentuated on deep inspiration?
Yes, sir.
Conducted to the axilla
No,
at the back?
axilla back it's not going.
Not axilla. More likely we try to yeah. The only thing that is not in concordance with your finding is the liver.
Yes.
You say with the severe TR, I would have expected the liver to be palpable, to be pulsatile, which I don't think according to your findings is not so.
So I think your final diagnosis, most of the things I would agree, but some things are missing. What is the most important thing that is missing? Anybody wants to add?
The history of
AF is fast ventricular rate or control ventricular rate?
So I've written towards atrial fibrillation.
I don't think, I didn't listen.
So sorry.
You told AF, but
AF is
not-
said, but it never said fast ventricular rate or control ventricular rate. So what is the definition of this fast ventricular rate and control ventricular rate?
More than
More than
110
100 is
fast ventricular rate.
More than?
100, sir.
Where is the definition from? So there's a trial that happened, like control ventricular rate of the fast
Yes, sir.
ventricular
There
rate.
was a.
You can use
strict
that
and
cutoff
linear.
rate, because
Yes.
there's no other way, there's definition of cutoff is there, but there's a control ventricular rate versus strict
There-
control versus lenient control.
Yes, sir. There was a trial that.
You can use the same definition. for
Yes,
that.
sir.
So what is
That
this rate?
110, sir.
110
Yes, fast ventricular.
is a fast
Fast
ventricular.
ventricular rate.
Fast ventricular response.
Clearly fast ventricular rate.
Really fast.
So some things I don't agree with. When did he last orthopnea?
So when he was admitted 15 days back,
So how can suddenly he become class 2? Just as a cardiologist, we cannot get functional class wrong.
so
So
he was,
somebody comes admitted with class 4 symptoms, he is still on admission. How can he be classified as class 2?
was a class 3 symptoms, like he's still having the failure symptoms.
He's
Krebs,
class 3 you say. Class 2 you say.
Class 2, I told, sir.
This classification, we cannot get it wrong as a cardiologist. Rest of the things are fine. Sir. The functional classification, you cannot get it wrong. So really you can say that he's class 4, is slightly improved, ambulatory class 4, or his class 3 also we may accept it on treatment. But class 2, I don't think I can accept it. And what about your PVH assessment?
severe PH, severe
He
PVH,
said moderate PVH.
severe PVH.
He said moderate PVH. That's why the query there. So how do you assess PVH for the sake of everybody? How do you assess the PVH in a given case of an RS?
Sir, PVH,
Multivalent RS?
sir, PVH is based on the pulmonary capillary wedge pressure. If
So what is like?
sir, here there will be interstitial edema. So the pulmonary capillary wedge pressure will be till 18 to 25.
No, somebody gets orthopnea.
Ah.
Somebody
that
gets
is
admitted with orthopnea.
PCWP more
Somebody
than
is-
So that is-
25.
As AF is fast ventricular rate, if this fellow, you cannot clinically classify as severe PVH, I don't think
Sir,
whichever
this,
you can
mod-
do.
sir, this moderate PVH I told currently, sir.
You cannot be so accurate. Let us keep it very simple.
Sir.
Somebody is class 4, somebody has CMD, orthopnea. There is no harm in calling it severe PVH. What are you doing? No examiner is going to tell you, how do you say, why do you say severe PVH? But the reverse is going to happen. And what are the other ways you will classify PVH? Because this is a common problem for everybody.
Amount of the pillows he used, if more than 2 pillows is used to sleep.
So basically, if one is on symptoms, how severe the symptoms of dyspnea?
Yes.
What else you want to use? Classify PVH. Obviously, it depends on the lesion also. Suppose somebody with dyspnea and the lesion is quite also will think of it. And more importantly, the amount of cardiomegaly.
Yes, sir.
That those are the ways you will classify PVH. It's always affected. And the other important ways in which you could classify PVH is the reverse calculus from your PH.
Yes, sir.
Because if somebody has severe PH, it's likely to have at least moderate or severe PH
Moderate.
because of a limited RD.
Will A2OS interval help you in assessing the PVH?
It's a severe it is, then severe the PVH.
Hmm?
Means narrow it is, like severe MS, then severe the PVH.
So it's basically indirect measurement. If the patient is having severe mitral stenosis, there will be high back pressure or pulmonary venous pressure.
Severe
That
PVH.
leads to the severe pulmonary venous pressure.
Do you think this tricuspid regurgitation is organic?
No, sir, in JVP, Y descent was there.
Hmm?
JVP, Y descent.
So it is a pansystolic
Yes.
murmur. So
Do
likely
you
to
get organic tricuspid regurgitation without tricuspid stenosis?
Yes, sir.
Yes.
Possible.
You can get.
Yes.
Yes.
But what is the incidence of isolated tricuspid regurgitation? Mitral. I mean, in the mitral stenosis, if there is no tricuspid stenosis, do you get an isolated tricuspid regurgitation commonly?
Rare.
The rheumatic heart disease.
Yesterday it was discussed, no? There was question also, how do we differentiate organic tricuspid regurgitation
So that
from functional tricuspid regurgitation?
so functional TR will be pansystolic, while
Pansystolic here,
organic
early
will be late
systolic.
systolic murmur. Sir.
It's just
Early
मतलब
systolic.
early.
नहीं early में plate में तो pass और fail के difference है.
Early systolic.
Early systolic. Okay, good. One is PA pressure. What are the things can be there?
सर उसमें loud P2 रहेगा अगर patient को
Features of
function
PA.
Types of PH can be there.
PH will
You are
be there.
getting everything here.
yes sir
But still can there be an organic involved?
Yes, superimposed can both can
Superimpose
be
अगर
It can be, we cannot differentiate, we cannot be sure, but more likely to be functional is likely to be there because other features of pH are there. But what is the proportion of tricyclical involvement in a given case of RH?
the 6% clinically, but autopsy cases like 30 to 40%.
30% is
30 to
will have
40%.
tried.
Different or different. One is clinical, echo,
And autopsy.
and surgical series, and then autopsy. So all the four are different.
Now you said that he has a PND. What is the life history of PND? Patient gets PND. What happens to these PND attacks as the time goes by?
So
Do
as
they
the
remain
time
same?
goes,
Do they increase or do they disappear?
so it decreases with the development of second stenosis, with the decreases with the development of right heart failure, and symptoms will improve. Then can be worsened with the heart failure again.
I'm not talking about heart, I'm talking about the PND.
With the severity, if the second stenosis develop, it might be come down.
Do they become more or they become less?
Less.
What's the mechanism of this?
Second stenosis.
So basically what happens because of the chronic fluid accumulation, fluid starts going in the interstitium that loses the air
Redistribution of the body.
redistribution of the body.
What happens to the alveolar?
So there will start alveolar thickening and the fibrosis.
Thickening also occurs.
Ah.
That also prevents the
That also plays.
Development.
And for a completion sake, it's better to say no rheumatic activity.
It's
Just
no.
for completion sake. Yeah, what is the one thing against your diagnosis? What you would have expected that's not there?
So liver dullness. Liver dullness.
Liver enlargement.
Liver enlargement,
Liver enlargement.
cardiomegaly. What about cardiomegaly? If you are thinking of severe TR that has produced fluid and everything, there is absolutely no cardiomegaly.
Yeah, there should be. Now there should be cardiomegaly and liver should be palpable or liver.
Can this be congenital lupus? Just for the sake of completion.
Symptom wise, no, sir. History is very,
Congenital lupus by and large never have opening snap. Very
Yes.
rarely they can have, but opening snap is not a feature of spinal limb. That is how they are.
What should happen to the right border of the heart if there's a severe tricuspid ventilation?
So it should extend more towards
Huh?
the.
Should you get some dullness of the right region, on
Dull.
the right border? But you said there was nothing on the right side.
in this case was not.
I think there's some odd features that you're describing for the tricuspid vegetation.
What you want to say first?
X-ray or ECG? What will help you more in your diagnosis?
X-rays.
X-ray. Anyway, we decide to show you the ECG first. See. And tell me in the ECG, what is not fitting into your diagnosis? And you have given a diagnosis, rheumatic valvular disease, severe mitral stenosis, severe PVH, severe PH, TR, atrial fibrillation. So what is not keeping with your diagnosis? No RVH in the ECG.
It's all the LVH. I didn't see the ECG.
No,
The DPS is when we go to
Yeah,
ECG.
I also saw very this thing, but there was no.
It's not a right axis deviation.
What is surprising?
So it's more of regular, but I think it's a flutter with 2:1 block.
Okay. What are the other findings? What were you expecting with your diagnosis?
Expecting, sir,
There is a right axis
axis.
deviation with LA enlargement is there, sir.
LA enlargement.
Sir, it flutter here.
it's a flutter P waves are in between we able to.
Flutter 2:1 AV control.
With your diagnosis, what is asking? With your diagnosis, what you would have expected on ECG?
Right axis deviation, sir.
Right axis deviation?
And right ventricular hypertrophy,
Yes,
are they there?
no, sir, RS.
IVH is not there, sir.
So how do you explain? There is no right axis, no right ventricular hypertrophy. You are telling atrial fibrillation, there is no atrial fibrillation. That one can understand, there is flutter. Let's be on ECG. So why there is no right axis, no right ventricular hypertrophy?
I think while we are looking at the ECG, but one prominent finding that you have not described this, just go and see the ECG, what is there? Is there anything pulsation? I think the right lobe of liver is enlarged, you are able to treat it there, and then clearly it goes, somebody, one of the. Pulsation, that's a prominent pulsation. Predominantly because
Is it a sinus rhythm or what is it? Or is it a flutter wave? Flutter like that. Flutter wave. Yeah. So with your so much pulmonary arterial hypertension, should have been a right axis deviation, right ventricle. So you want to change the diagnosis or?
What ventricular chamber is enlargement? Now describe the ECG, let's go back there. Can you go ahead? No, there's an ECG there.
So it's a 12-lead normal standardized ECG. It's a regular reading, but there is no P wave. It's a atrial flutter with 2:1 block. Axis is around 90 degree.
Why 90 degree? Not exactly 90, no? Like 90 means what should be there which is not there?
Lead 3.
Equiphasic in one should be there if you are saying 90, it is not there. So then what it is?
Lead 1 is positive.
Lead 1 is positive, AVL is negative. So what is the axis?
Right X. Right. More going plus.
AVL is negative and lead 1 is positive.
Yes.
So that means equiphasic is somewhere in between. So that will be minus 15 equiphasic. So your axis is going to be plus 75. These things you should be very clear at this level.
And there is LVH,
Sorry?
left ventricular enlargement.
LVH.
By
What the criteria that you are
coronal voltage criteria, like V3 is more than 25 for male. It's there.
So can you now explain why there is no RV?
See, I think when you look at the ECG, there's things to start describing what is the rate, what is the rhythm like. You look at the bottom strip, what does it show? It shows an atrial fibrillation or not? Right at the bottom.
Yes, sir. In last
There is a rhythm
irregularities,
strip.
rhythm strip, there is irregularity. RR is changed.
What is it?
AF.
Atrial fibrillation.
Yeah, flutter.
And what is the axis like?
Normal.
Normal. And what about the chamber, ventricular chamber enlargement?
Left ventricular enlargement.
Left ventricular enlargement. Now, does this go against your diagnosis?
No, sir.
It doesn't go against the diagnosis.
No,
Now,
it
you
goes
said
against the
there's a
diagnosis.
Again,
So there should be RVH. sir.
Hypertension, severe tricuspid regurgitation. You say there is no mitral regurgitation. So how do you explain this left ventricular hypertrophy?
So there should,
There should
like there might be associated
think-
MRs
Associated MR
or
could be
can
the possibility.
explain this.
So would you like to change now? They say that the systolic and systolic murmur that you heard.
Possible.
Two murmurs we can add. One is TR and one is MR murmur.
Now you're saying tricuspid regurgitation and mitral regurgitation both.
Both.
Right?
Possible.
Yes.
So why there is a tricuspid regurgitation when there are no signs of pulmonary abscess on the ECG?
Do you think you might have missed AR in this patient?
AR.
So
It's
there is
possible
no
that,
wide pulse pressure or.
Means BP wise, we measured by oscillometric first off. And that could be like not able to pick up the low
What
diastolic
what
pressure.
happens to signs of AR?
In presence of heart failure, it is masked. As the patient is like crackles in basal, NYHA class 3, heart failure symptoms can be masked. And in presence of multivalvular disease like associated can NYHA.
Now, I'll ask you, you are sitting in your consulting room office. Now you saw the patient, now you saw the ECG. So what diagnosis will you offer?
So I'll think of severe MS with.
Would you like to send him for mitral valvotomy or You will send him for mitral valve replacement.
MVR.
What will you,
Replacement.
huh?
Replacement.
Replacement.
Yes, sir.
I mean, this is
Yes.
the first thought in your
Like this is
mind.
the first thing I'll think it
I
is
don't
not for
think it
valvular
will
topic.
be confirmed. Maybe you will do an echo and you will do an
Yes.
X-ray.
But predominantly.
Let's see the X-ray.
One more thing is, why there is no RBH? You didn't answer this question. Why there is no RBH on ECG? In other words, what is the sensitivity and specificity of biventricular hypertrophy on ECG? When somebody has LVH, what is the sensitivity specificity of biventricular hypertrophy with ECG?
Say decrease also.
Drastically
Cross
decreased.
state, huh.
So what are the ways to diagnose biventricular hypertrophy in ECG?
ECG, we can get Cat's basal phenomenon.
That is very rare, only found in children with VLD.
Yes, there can be RBH with left axis
with right
deviation
axis
or
deviation.
LA enlargement features, sir.
So number one is you find features of RBH and LVH in the same ECG,
Yes.
which is uncommon. And second one is, as you say, axis versus LVH with
Axis
right
versus-
axis. It's almost rightward axis in this case also.
Yes, sir.
So, but because these two cancel out each other, the electrical forces cancel out each other at times. That is why you don't find often RBH when you have such significant LVH.
Okay, I'll ask you one question. You heard the first sound to be very loud, right? Can this be explained by his body state? The man is very thin chest wall. You can see his ribs are big thin. There is no muscle. Muscle seen on his chest. Did you look for any neurotoxicosis?
So as if there is no thyroid or means thyroid enlargement is not there.
No, but at least looking at it. Yes,
I don't.
Could be explained on the basis of.
Emaciated, yes,
Rather than a
can be.
valvular pathology.
So it can be.
Because now once you've got left ventricular hypertrophy, you've got to go back on your diagnosis.
Either MR or both, what you want to put your money on.
MR, sir.
Clinically, there is no features of it.
What happens to the first sound in the patient who has got a significant ER?
It's soft, sir.
It's soft.
Yes.
So it is according to loud. On that count, and plus what happens to the pulse pressure?
There'll be white pulse
White
pressure.
pulse
Right, what is the pulse pressure?
So it is only
It's
30.
normal,
Malab.
So at least on that you can rule out clinically you can rule out significant ER.
Significant AR we can rule out.
Most of the severe AR is not there, but we would easily list a moderate AR number because
Yes.
the heart rates are almost 125 now.
Yes, sir.
So we could easily miss a AR number if it is there only.
Just X-ray.
Can you?
And
Yes, sir.
it,
Chest X-ray peer view, showing there is a massive pleural effusion on the right side. Still, heart is well centered, it's not shifted. And there is a difficult to say.
So there is no evidence of any cardiomegaly with mild PH.
so because of this massive pleural effusion, you won't be able to comment on many things. So that's what you should say. That first I'd like to tap this pleural effusion and see an X-ray after tapping. Then you can get some other signs, which you are looking for. Now that will be the limitation of this X-ray.
Is it threatening of left heart border?
Straightening, so it is. There is not.
But what about I say there is collapse because of massive pleural effusion and then there is a shift of the heart towards the left side, or there is cardiomegaly. What is against that argument?
Okay.
So that
Yes,
trachea
there
should be
is so
pushed
much of
towards-
pleural effusion, you don't expect the heart to be pulled.
Heart to be pulled there.
The trachea is in the center, right?
Central,
Yes, trachea in central position.
What about PVH? What about PAH?
CVS, PVH,
So it's difficult to.
What is the evidence for severe PVH?
pleural effusion. Pleural effusion.
Difficult to comment on this, sir, but
Difficult to comment.
comment.
So what are the phase to grade PVH?
So in PVH,
Cephalization is the grade 1, then grade 2 is the curly B lines. Then grade 3 we can get visceral edema and
bad wing operation.
Bad wing
Bad wing operation.
What about PH?
pH like here's a pulmonary artery enlargement not that.
So in mild dilatation of the pulmonary artery can be appreciated on the left side. So left
No, it is actually significant. Like you
this-
don't get left pulmonary artery dilatation like this.
Yes, sir. There's
Like
significant
grade-
dilatation of the left pulmonary arteries.
Clearly dilated.
Yes. with mild peripheral pruning.
Anyway, I think, what I would suggest, we should rewrite your
And he
diagnosis.
wrote echo report.
Sure. Echo, yeah.
So it just says severe MR, moderate MR, mild AS with moderate AR, moderate ER with moderate PH. Right? With global LV hyperkinesia, with severe LV systolic dysfunction. With MBA of 1, ejection fraction. Axial gradient of 27. Mean lateral gradient of 27 by ED of 30. And ejection fraction of 32% with a TAPC of 1.7. So moderate AR resistance is this way. It's an axial resistance. So moderate MR and moderate AR.
I think these two explain the ECG.
ECG, LV enlargement.
Okay, I think. Very good.
Say, what I was telling yesterday in my talk of multivalvular disease, that in those patients of mitral stenosis, where there is pulmonary hypertension, cardiac output has fallen, there may be, you can miss some signs of aortic regurgitation. So when such a question is asked at this stage, you should at least be open that it is possible that these signs would have been missed. The other thing which you can say is that I like to further make this patient out of heart failure and then reassess the clinical signs. Many times the clinical signs appear when the heart failure has been treated. So these are the important lessons. And again, as Sir was asking you, the difference between TR and MR, in such a situation when patient has been such a heart failure, the chances of a mixed mitral lesion is there. So you should be open and look at it. Look about it.
I think one of them very well.
And
Yeah,
also, I would feel that in presence of the massive pleural effusion, we certainly mask all the signs.
Yes, sir.
and they will certainly alter the sign. And plus, I think what you were getting first thousand in love is because it's thin chest wall.
Yes.
And that's why you're feeling. Also, I
LV
think it was
dysfunction
purpose
also.
recorded.
LV dysfunction
And I
also.
thought
It
that
must have been
that could be
rapid
a
rate he has
for
come.
that.
Second is.
Could you explain any of this? I think there was a left ventricular pathology that one had to explain.
Both of them done very well, so give them a big hand.
Very good.
Really, lot of stress to stand in front of everybody and expose yourself. Very good, well done. Hard question, are you passing them or good? Passing them is distinct. Oh, great, thank you.
No, sir.
So, you think that you want to history-wise create a life, justify.
Yes, sir. ECG and X-ray was totally different.
ECG was different, so yeah. Yes. It was difficult.
You were very categorical, there was no MR at all. Both of you were very strong on PR. Why you good at that moment? But subsequently,
It was.
there are really some examiners not at all. Anyway, thank you. Moving on the second case, it's a named as short case, but of course it will depend on the examiners. So I request this will be the Umaruvelu and the other gentleman. Manohar. These two candidates of the present them the next case. Are they there? Yeah, while we are waiting, so how do you assess ventricular function in RSV case? So this patient had 30%, we didn't comment on it. But what are the ways to assess LV function in an RSV case? So some rules are there, like for example, it's very difficult to assess clinically. But if we find a Vesperian's pulse, that means almost always the LV function is normal. Such rapid ejection has to be there to produce a Vesperian pulse. That means generally, by and large, LV function is normal. As he is trying to point out, you find a dilated apical impulse. You find, for example, MR or AR. You expect the apex to be dilated, but instead you start finding heaving nature of apex. That indicates likely the LV is starting to fail. So in other words, a dilated apex where you want dilated apex to be heard, you start feeling heaving apical impulse, then you should think of LV disease. And the reverse is also true. You find a AS is there, patient with AS, you want to have a heaving apical impulse in the right place, in the correct place. If you start finding a dilated apex, that situation, and you start diffuse apical impulse found in a heaving apical impulse situation, you should start thinking of LV disease. And the proportional pulse pressure. What is proportional pulse pressure? So I think you should read about that, like pulse pressure.
Okay, good. So moving on the second case, our examiners would be Dr. B. Srinivas, he's actually for Nizams, and I'll ask Rama again to be there. And then Dr. Allegation.